Welcome to Triage Cancer's webinar, Genetics and Genomics. My name is Madison McMahon Ward, and I am the Program Coordinator for Triage Cancer. I will be moderating today's webinar. Now, before we dive into today's topic, I just need to go over some housekeeping. All callers will be muted for the duration of the webinar. If you have any questions or technical problems, please type them in the question box to the side of your screen. This webinar is being recorded and will be available for viewing by the end of the week on our website, triagecancer.org. After today's session, you will receive an email with a link to an evaluation. We would appreciate it if you could take a few moments to provide your feedback. We are very grateful to Genomic Health for sponsoring today's webinar. As part of the accreditation process for healthcare professionals, we have to read the following disclaimers and disclosures to you. This presentation is intended to provide general information on the topics presented. It is provided with the understanding that the author is not engaged in rendering any legal, medical, or professional services. The planners and presenters for this program have not disclosed any pertinent financial relationships or conflicts of interest. While this educational program has received commercial support from the previously listed sponsor, the content of the program has no relation to the commercial interests of the organization's products or services. I am very pleased to let you know that Triage Cancer is an accredited provider of continuing nursing education by the American Nurses Credentialing Center's Commission on Accreditation. This program is also approved by the National Association of Social Workers for one continuing education contact hour. Therefore, nurses and social workers participating in the live webinar and meeting the following requirements may be eligible for one contact hour of credit. In order to receive contact hours, you must have registered online for today's session. People who are listening in on someone else's computer are not eligible for credit. You also must attend the entire webinar. No partial credit will be awarded. Anyone watching a recording of this webinar will also not be eligible for credit. Within 1 week of this webinar, complete an evaluation and post-test. You must receive a passing grade on the post-test to be eligible for contact hours. You will receive an email following this webinar, which will contain a link to the evaluation and post-test. Please note on the evaluation, it asks for your name and email address. You must include these so that we can certify that you completed the evaluation. That email is the address we will use to mail the certificates. We will be sending out certificates within 4 weeks. For other types of healthcare professionals, we are more than happy to provide a general certificate of attendance. Just make sure to indicate that request on your evaluation. If you have any questions or experience any problems, email us at info@triagecancer.org. For those of you who aren't aware, Triage Cancer is a national nonprofit organization that provides education on the legal and practical issues that may impact individuals diagnosed with cancer and their caregivers. And we provide this education in a few different ways. First, we host a speakers bureau of experts in all types of cancer survivorship issues available to organizations putting on an educational event. You can read our speakers' bios and request a speaker on our website. We also participate in events all over the country. Some of these events are hosted by our partners in the cancer community, and some are events we host ourselves. To see where we are going to be, take a look at our events calendar. Every year, we host 3 Triage Cancer conferences. This day-long event covers a variety of cancer survivorship topics. We welcome patients, survivors, caregivers, advocates, and healthcare professionals at this free event. This year will be in Chapel Hill, North Carolina, and Houston, Texas. Registration is now open. As you know, we host a monthly webinar series open to anyone in the cancer community. The next one is on September 19th, covering Understanding Hospice. Recordings of past webinars are also available on our website. We also host 2 educational programs that are specific to healthcare providers. The first is the In-Service for Healthcare Professionals, Navigating Cancer, Work and Insurance. This program is delivered in partnership with Cancer and Careers. The second training for healthcare professionals is the Insurance and Finance Intensive. This is a comprehensive certificate program for oncology healthcare professionals and advocates on health and disability insurance and finances. You can get more information and register for any one of these programs on our website under the Events tab. In addition to our events, we offer a number of educational materials and resources online. Our quick guides are designed to be a snapshot of a particular topic. They cover areas such as health insurance, employment, clinical trials, financial topics, estate planning, and legal assistance. We also have checklists and other documents designed to help with the legal and practical pieces of cancer survivorship. All of these documents can be downloaded for free on our website, or you may order hard copies of these materials on our website at triagecancer.org/material request. Because we recognize everyone learns in different ways, we also provide educational animated videos on cancer survivorship topics. We recently released 2 new videos, one on clinical trials and one on cancer survivorship care plans. We also have videos on health insurance and employment topics. These videos are available in English and Spanish, and stay tuned as we have more videos coming soon. We are very excited to announce that thanks to the support of the California Dialogue on Cancer and Genentech, we now have several resources available in Spanish, including most of our quick guides and all of our animated videos. Again, these quick guides can be downloaded for free on our website. We realize that it can be challenging to find what you are looking for on the internet, so we compiled the contact information for some of the most frequently used state-specific agencies and resources on our website. And because where you live can impact what protections you have access to, we have charts of state laws on employment, disability, health insurance, and other cancer-related issues. Cancerfinances.org is a site that we host in partnership with the SAM Fund that provides practical information on topics that can impact your finances. This website is designed to guide users to the information that is most relevant to their situation. We currently have modules on health insurance, disability insurance, education rights, estate planning, life insurance, and financial assistance resources. More topics will be added soon. And finally, our educational blog not only provides great information about cancer survivorship topics, but because things are constantly changing in the cancer community, this is how we share late-breaking news. And we have our monthly e-newsletter, which is where we announce all of our upcoming events. With no further ado, let me introduce today's speaker, Dr. Christy Russell. After earning her medical degree from the Medical College of Pennsylvania, she completed a residency in internal medicine at the Good Samaritan Medical Center and Phoenix Veterans Hospital in Phoenix, and a fellowship in hematology oncology at the Los Angeles County University of Southern California Medical Center in Los Angeles. Dr. Russell joined the USC Department of Medicine faculty in 1986. She remained on the faculty for 31 years and served in many capacities, including the director of the USC Norris Breast Cancer Center, the director of utilization review at the USC Norris Cancer Center, and co-chair of the USC Comprehensive Cancer Center Data Safety Monitoring Board. Dr. Russell joined Genomic Health as a Senior Director of U.S. Medical Affairs in January 2017. She has served the cancer community extensively in a variety of roles. For the sake of time, I will not list them all here, but you can read her complete bio on our website under the link to this webinar. Remember, if you have any questions, type them in the question box to the side of your screen, and Dr. Russell will answer them towards the end of the presentation. So with that, I'd like to turn it over to Dr. Russell.
Thank you. Hi, everybody. So what I'm going to talk about today is genomics, but what I will do in the beginning is to help people understand the difference between what genetics and genomics are. Right. So I am not, there we go. Okay, so we're going to define the difference between the two. We'll talk about how oncology care has changed over the last 40 years. Have we made progress? What does this genomic information add to patient care? And how do we speak to our patients as physicians or as healthcare providers with regards to these changes? The other question is, what can we offer to patients with early stage breast cancer and with later stage cancers? And can these tools help us guide decisions for the therapies that we're going to recommend? So we actually will, I want you to type in questions during the presentation, but we're going to wait till the end to address all of them. Okay, so the question is, how do we define genetics and genomics? What is the difference between them? Genetics is the study of heredity. So especially in the breast cancer field, you'll be hearing about BRCA genes and that sort of things. So genetics is focusing on the likelihood of developing a cancer. These are genes that you're born with. These are not genes that are within the cancer, but they're within every cell in your body. And so while genetics can influence genomics, genetics in and of themselves, genes that are abnormal that you are born with, are responsible for somewhere between 5 and 10% of all breast cancers that develop. So the majority of people who get breast cancer get it for reasons unrelated to genes that they're born with. So genetic tests don't find cancer, they find mutations in the genes. Genomics is then the study of how genes interact with one another and how they're expressed. So genomics and gene expression profiling tools, or the testing that we use for genomics, focus on the cancer and what the cancer is doing. So we're looking at the genes within the cancer, and these genes can tell us how aggressive the cancer could be, which is called prognosis, or can it help us predict which therapies will work? And that is called prediction. So that's genomics versus genetics. So an example of a genetic test is a test used to predict whether someone is going to develop a specific cancer. And I'm giving two examples here. One of the BRCA genes. BRCA means breast cancer. We've absolutely defined BRCA1 and 2, and these are patients that have a mutation within these genes that give them a much higher chance of developing breast, ovarian cancer, and many other cancers. I'm going to sneeze, sorry. Then secondly, there are genes that are called the APC genes. These are adenomatous polyposis coli genes, and these will then give risk to developing many colon polyps or colon cancer. So these are just two big examples of heredity. You're born with these genes, and these genes are abnormal in every cell in your body, but they only seem to be affecting certain organs, thus giving you chances of cancer in those specific organs. A genomic test, I'm going to give an example, which is called Oncotype DX breast cancer assay. And just as a disclaimer, I am a physician. I was on the oncology faculty at University of Southern California, but I am now employed by Genomic Health, who does produce the Oncotype DX breast cancer assay. So this will be the providing example that I'll give, but there are many other genomic tests that are available as well. So this assay specifically looks at 21 genes within breast cancer tissue from patients who have already been diagnosed with breast cancer. The assay evaluates a couple things. Once you have early breast cancer, it helps understand your risk of having a recurrence of the breast cancer, either locally or in a metastatic setting, far reaching away from the breast. And it also predicts who will benefit from chemotherapy and who will not benefit from chemotherapy, and who gets benefit from hormone therapies like tamoxifen or a group of drugs called aromatase inhibitors. So what do genomics do for us? They allow us to have early and accurate diagnoses of cancers. They give much greater individualization of treatment decisions. They can help us understand specific targeted therapy based on the genes from that individual person's cancer. They give you much greater likelihood that if you're in a clinical trial that it will be a successful clinical trial, because we're really putting patients in the clinical trial with a known gene abnormality rather than all patients with a specific cancer. It's really helped us drive more rational drug discovery, rather than creating a drug that we might think will work in all breast cancer. We can focus our drug discovery on specific gene abnormalities and see if we can find a drug that'll address those abnormalities. And it's really helped quicken drug development by allowing clinical trials to perhaps be smaller, because we're really focusing on a subset of patients that have the greatest chance of benefiting. So normal gene expression and the interaction of genes, that's what biology is all about. And so now we've got biology, which is just how all genes are expressed and function within the body, those that you're born with and those that are developing abnormally within breast cancer cells. So there's a lot of words out there about precision medicine, and it's probably a term that's well overused. But let me just kind of walk you through breast cancer and examples of how we've become much more precise in the therapies we're considering for breast cancer. The first generation of genes that we looked at, we're looking at genes protein expression. So all genes do in our body is make proteins. They make a cell make a protein. And so a lot of our original discovery, we're looking at the different proteins in the cancer cells and how they're being expressed. So in the 1970s, we were able to look at the expression of the estrogen receptor and progesterone receptor in breast cancer cells. And you can see on the right-hand side a little picture of staining of those proteins in the cancer cells. Now, those proteins are made by the estrogen receptor gene and the progesterone receptor gene, which are in the DNA. But again, they're making a protein, and we can measure how much protein is in the cancer cell. The next generation, and this was explorations that occurred in the 1990s, we're now looking at amplification of genes. So now you have a gene. You're supposed to have 2 copies of every gene in every cell in your body. And we've discovered that some cells have genes that are amplified, meaning instead of having 2 copies of the gene, you could have 10 or 20 copies of the gene. And then all those extra copies of the gene are making protein. So we could either measure, is the gene amplified? Are there more than 2 copies that are in the cancer cell? Or we can measure for the protein that that gene is making. The most common testing we're doing now for gene amplification in breast cancer is HER2. The technology is called FISH, and you see an example of the FISH on the right-hand side, so the second box down, where we are labeling with fluorescence the chromosome that the HER2 gene sits on, and there are 2 chromosomes in every cell in the body, and then there should be 1 gene per chromosome. And we're looking as to whether the ratio between the genes and the chromosome is 1-to-1, which it should be. And in this case, we're seeing the pink has many, many more copies of the gene than we should expect for the little green dots, which are the actual gene or the chromosome itself. So those are called gene amplification, and that's used a lot in the breast cancer world, but in other cancers as well, to use targeted therapies that will just interact with that gene abnormality. Then the next generation are genomics, these gene expression assays. And Oncotype DX, which has this breast cancer recurrence score, is one of these genes, but there are others as well that are on the market, one called MammaPrint, the Breast Cancer Index, PAM50, and EndoPredict. And these are all commercial assays that are genomic assays we use in breast cancer, but we don't use more than one. They each actually measure different genes. Every one of them is prognostic, meaning if you have a high test or low test, you can understand the patient's risk of her cancer coming back again. But the only one of these that can actually help us understand whether chemotherapy is going to work or not is the Oncotype DX test. And finally, we're now into what we're calling fourth generation mutation profiling. These are looking at individual genes within cancer cells to see if there's a specific mutation for which we have a drug that will work. And now there are companies out there that have large panels of genes looking at specific mutations. One company, there are many companies out there, but one's called Foundation Medicine, and it will test the cancer's 300 to 400 genes looking at specific mutations. So we've come a long way in not that, long a period of time. We went from just protein measurements on cancer cells to these mutational profiles, which are now becoming much more standard for patients with advanced cancer, and we're trying to understand how to use them with early cancers. All right, so we're going to really focus on the genetics or genomics of the third generation assays. All right, so let's go back and talk about breast cancer in patients with early breast cancer. We know that there are three big buckets of breast cancer, and there are many more, but I'm going to kind of bring this down and simplify it. One is, if you look at the circle on the bottom, if you look at patients that have a breast cancer that has an estrogen receptor, so we test that on everybody, that protein in the cancer cell, we know that if you take 100 women with an estrogen receptor positive breast cancer and you give her hormone therapy, a drug like tamoxifen or an aromatase inhibitor, we can see that for women who have lymph node negative breast cancer, that 85% of patients who take these drugs for 5 years will not have a recurrence of her cancer within 10 years, but 15% of patients will have a recurrence. So hormone therapy can be very, very effective in reducing the risk of the cancer coming back. What does chemotherapy do for these patients with an estrogen receptor positive breast cancer? So if we have 100 women with an estrogen receptor positive breast cancer that's lymph node negative, we know that 85 of them won't have a recurrence. We know that 15% will. So if we add chemotherapy on top of our hormone therapy, only about 4% of patients actually don't recur because we added in chemotherapy. And so there's a very small number of women who actually benefit from chemotherapy with these estrogen receptor positive cancers. And then you look at that 11%, and that's the 11% who are still going to relapse with their cancer with metastases elsewhere in their body, despite the fact they took estrogen blockers and chemotherapy, and they're still left with this big leftover risk. So we need to figure out better ways of figuring out who will have a recurrence so we can minimize the therapies we use for patients who are never destined to have a recurrence, and then optimize which therapies are best based on the genomics of their cancer. So will their cancer spread? Do they need chemotherapy for their cancer type? What are the benefits and side effects of the chemotherapy? Are there any new drugs based on genomics for the cancer? And here's the questions patients really want to know. Am I going to survive this, or will I die prematurely as a result of having had this cancer? And we're trying to understand whether genomics can help us answer all of these questions. So when we have a patient with early breast cancer, this is very kind of rudimentary way we think about things. When we remove the cancer, the first thing we're looking at is the patient's tumor size. Then we want to know how many lymph nodes are involved, because the more lymph nodes involved, the more likely it is cancer got into the bloodstream and will be found elsewhere in the body at some point. We look at the patient's age. Very, very young women with breast cancer are more likely to have a recurrence, or certainly more likely to have a more aggressive form of the cancer. We look at grade of the cancer. Grade is how aggressive the cells look under the microscope. The pathologists look at the cancer cells and tell us what the grade of the cancer is. And then we test the cancer for those three things we talked about: estrogen receptor, progesterone receptor, and what the HER2 gene is doing. We want that gene to be normal, but if it's amplified, we want to know how many copies of that gene there is and how much protein it's making. There were computer-based models that used all of those things that help predict the risk that the cancer is coming back, but that has now been supplanted or replaced by genomics, and I'm going to again concentrate on the Oncotype DX assay. All right, so if we're going to do genomics, how do we do this? Well, the cancer is sent to the genomic lab. In this example, the tumor is sent to the genomic health laboratories. The assay is sent to the laboratory. They analyze how these 21 different genes are functioning, whether they're over-functioning or under-functioning, and we put together in a mathematical model a number which is the Oncotype score, which is between 0 and 100, that then helps us understand the risk of the cancer coming back and whether there's a benefit from chemotherapy. This is provided to the patient's surgeon or oncologist, and then there's a discussion with the patient to include the patient in shared decision making, so he or she can say, yeah, that's my risk, this is the chemo benefit, and whether that's enough for them to consider taking chemotherapy or not. So just more on this breast cancer recurrence score. We used to think through the 70s and a lot of the 80s that it's one size fits all for breast cancer. Remove the cancer. If you just do a lumpectomy and you leave breast tissue behind, you need to radiate. And then we started to do hormone receptor testing, that estrogen and progesterone receptor. 70% of patients with early breast cancer have an either estrogen or progesterone receptor positive cancer, which means they will react to estrogen. They will grow under the effect of estrogen. So we want to use an estrogen blocker. And we know that if we use an estrogen blocker, either tamoxifen or these other classes of drugs called aromatase inhibitors, you get almost a 50% reduction in the risk that your cancer is ever going to come back again. So very, very powerful therapy. And then we moved into the HER2 testing that I spoke about. About 20% of patients have a HER2 positive breast cancer. Again, this is genomics. This is testing of the cancer. These are not genes that you're born with that give you a risk of cancer. These are things that develop after the cancer's already occurred. And we know that the use of this drug called trastuzumab or Herceptin gives an additional almost 40% reduction in the risk of the cancer coming back or growing. So now you have about 70% of patients are hormone receptor positive. Of all the patients who get breast cancer, about 20% are HER2 positive. Some of the HER2 positives also have an estrogen receptor, so these aren't exclusive to one another. And then finally, let's look at the patients who have an estrogen receptor, they're HER2 negative, and we do this genomic test called Oncotype that helps us understand the potential benefit of chemotherapy, because if you're hormone receptor positive, we're going to recommend to patients they receive some kind of estrogen blocker. So we now know that more than 80% of patients have a recurrence score test. Again, that's on a 0 to 100 basis. If it's anywhere between 0 and 25, there's very little to no benefit from chemotherapy. And then if the recurrence score is 26 to 100, there's a very significant benefit from chemotherapy. And we can now make decisions or guidance around that information. So quickly, what's the Oncotype test? It's 21 genes. 16 are breast cancer related genes. 5 are reference genes. We used to have cutoffs that were low, intermediate, and high risk. And you can see the numbers on the bottom. It's a range of 0 to 100, but we used to say that recurrence scores 0 to 17 had a very low risk and had no benefit from chemotherapy, and those with this very high risk, recurrence scores 31 and 100, had an enormous benefit of chemotherapy. And we went for 10, 15, 20 years having this intermediate risk where we weren't really sure how much chemotherapy benefit there was. And this caused some consternation for physicians and for patients, not really wanting to have their cancer tested with a genomic test to be left without answers as to how much benefit they could really expect from chemotherapy. So we got the tumor blocks from this old trial for women who got tamoxifen or did not get tamoxifen. They were all estrogen receptor positive. And we saw that when we tested with this oncotype recurrence score, that patients in the low range in that green line up above, that after 5 years of taking tamoxifen, this estrogen blocker, 7% of them had had a relapse of their cancer. And we saw when they were in the intermediate range, 14% had had a recurrence of their cancer. And if they were in the high range, a third of patients are having a recurrence of their cancer. This is what we call prognosis. This gene testing can be pretty exacting in terms of what your risk is of your cancer coming back somewhere else in your body if you take 5 years of your hormone blocker. So we then created this curve that says on the bottom, you can see the recurrence score. The higher it is, the more likely it is your cancer is going to come back somewhere else in your body within 10 years. And again, we blocked off this low, intermediate, and high. So the blue line there is just reflecting, I'm not sure you can see my arrow, but just reflecting the higher the recurrence score, the higher the chance your cancer is going to come back again if you take an estrogen blocker alone. So we say, okay, let's figure out who gets chemotherapy benefit then. So we went to another study. That study is called B20. And the black line there are women who were in the original study. The solid black line are women who got chemotherapy plus tamoxifen, and the dotted line are women who got tamoxifen alone. And for all these women, hundreds and hundreds of women who were in this study, there's only about a 4.5% absolute benefit from chemotherapy. And when you look at the black dotted line, there's all kinds of women here who are getting no benefit from chemotherapy, and just this 4.5% do. So we got the cancers from the women in this trial and we tested them with the 21 genes. And we can see that if you're in the low range, that's this green set of lines, there's no chemotherapy benefit. And the yellow lines are cancers that are in the intermediate range, that 18 to 30. Maybe there's a little bit of chemotherapy benefit. We weren't sure. And then we saw these patients with these really high scores. They don't have 4% benefit of chemotherapy. They had almost a 30% absolute benefit from chemotherapy. That's huge. That means that if you have a 50% chance that your cancer is coming back, if you take chemotherapy, we get rid of almost 30% of that. Now you're down to a 20% risk. So it's important to define who these patients are and not give everybody chemotherapy. So when we look at graphs and curves of patients from that trial, you can see on the left, these are women who got tamoxifen alone from that study. These are women who got chemotherapy plus tamoxifen, and you can see the higher this recurrence score, these 21 gene testings are, the more benefit you're getting from chemotherapy, and that's reflected over here as well. So we did this huge trial in this country. It was called TAILORx. And what did TAILORx do? TAILORx said, okay, we have big benefit of chemotherapy if you're in this high range. There's no benefit of chemotherapy down here. Let's ask the question, who gets chemotherapy benefit in here? Because we don't want to treat everybody with chemotherapy who's in that mid-range unless we know they can really get chemotherapy benefit. So this trial is the largest trial that's ever been done for early hormone receptor positive breast cancer. There are 10,000 really brave women who agreed to go into this trial and allowed a computer to randomly assign them to chemotherapy or not. And so patients who were sitting in the really low range of the recurrence score were put on just an estrogen blocker alone. People sitting in the high range absolutely had to have chemotherapy and a hormone blocker. And then women sitting in this middle range were given by a computer deciding whether they would just get an estrogen blocker alone or estrogen blocker plus chemotherapy. We're trying to figure out in that mid-range of genomic scoring who does and doesn't benefit from chemotherapy so we can really tailor this for patients. And what did it show? It showed for 6,700 women who were randomly assigned to chemotherapy with that mid-range recurrence score, we didn't see chemotherapy benefit. These are two curves sitting right on top of one another. That's disease-free survival. These are distant recurrences like liver, lung mets, or bone mets. And if your recurrence score is 11 to 25, we didn't see anything. So then the question is, wow, we did this huge 10,000 woman trial trying to figure out where chemotherapy benefit begins, what number on your recurrence score range, and where we thought we would see the benefit was recurrence score between 11 and 25, and we did not see that. So the statisticians from this trial went back and said, somebody's got to be benefiting from chemotherapy in those groups. Let's start looking at patients who got this genomic test. Their recurrence score is 11 to 25. They don't seem to be getting chemo benefit, although we thought somebody would. So now let's add on other things. Let's add on tumor size. Let's say little cancers in that range might not benefit, but maybe big cancers do. Or maybe cancers with what we call low grade, really orderly looking cancers don't benefit, but wild looking cancers do. Or menopause status, or the age of the patient. We added all these things and said, do any of those things help us understand if the recurrence score is 11 to 25, who does and does not benefit from chemotherapy? And what it showed was no, none of those things mattered. But there was something that did matter, and that was age. And so this is getting really complicated, but on the right-hand side, we saw that for women in this study, almost 4,500 of them who were over the age of 50, if their recurrence score was 11 to 25, we don't see separation of these curves, which means there's no chemotherapy benefit. But we saw in women who were 50 and younger, 2,200 women in this study with recurrence score, again, 11 to 25, which is where we thought we'd see chemotherapy benefit. We actually start to see chemotherapy benefit with these recurrence score ranges around 15, and it increases as it goes up. What does that look like on a graph? So these are young women in the study. If they have really low recurrence scores, they get no chemo benefit. When they are in this kind of mid-range, they get 1.6% benefit from chemotherapy. You know, if it were me, I'd say, okay, you're telling me I have a 10% chance that my cancer is going to come back, and you can lower that to 8.4% if I take chemotherapy. That's something the patient needs to decide with her physician. But if her recurrence score is 21 to 25, we saw a movement of 6.5% benefit. What that means is if you have a 10% risk your cancer is coming back, and if you took chemotherapy with your recurrence score range here, you went from a 10% chance, you take 6.5% off of that, and you go down to a 3.5% chance. That feels like a really big difference to me, and I think that's the kind of information that patients need and physicians need to guide them to make these decisions of taking chemotherapy or not. So as a result of that, let me just go back. Who are these women? I can tell you that for women who are over the age of 50, 85% of them will be in the range where we will not recommend chemotherapy, and 15% will be in a range where we will. If you're 50 and younger, this lower group here is about 50% of all women should not be given chemotherapy. And then as the recurrence score goes over 16, then you can have individual discussions with the patients who are in this range about whether they should consider chemotherapy or not. And when they get into this really high range, it's something they should absolutely consider. There are two major guideline groups in the United States. One is NCCN, the other is the ASCO guidelines. And after TAILORx reported, it was such a significant trial being reported in this country, they changed their guidelines. And so right now the guidelines, these are for patients who are lymph node negative, have an estrogen receptor positive cancer, which is HER2 negative or HER2 normal. If the cancer is anywhere over 5 millimeters, the wording is, we strongly are recommending that the physician consider ordering on their patient's cancer this 21 gene assay, or this Oncotype score. And they're saying if the recurrence score is 0 to 25, just give her an estrogen blocker. If it's 31 to 100, she absolutely must take chemotherapy. But if it's 26 to 30, you gotta look at other features and look especially at the patient's age, because if she's older, maybe you don't feel like there's that much benefit from chemotherapy in this range. But for young women, the guidelines come down here to this box to say if they're 50 or younger and have that recurrence score in that 16 to 25 range, you need to know those data so that you can make decisions about whether you're going to recommend chemo and whether the patient will accept chemotherapy, knowing their individual benefit from chemotherapy. And in June of this year, ASCO changed their guidelines and they look almost identical. Again, if you're over 50 and you have a recurrence score of 0 to 25, or if you're young and you have a recurrence score of 0 to 15, endocrine therapy alone, an estrogen blocker, and then it gives guidance as to who should and should not be offered chemotherapy. I think the most important thing is you can't know how much benefit you'll get from chemotherapy based on your age, your tumor size, how aggressive it looks, if it has an estrogen receptor, and if it's HER2 negative, unless you do a genomic test. And this genomic test, this 21 gene test, is the only one that is giving us information about who does and does not benefit from chemotherapy. So overall, for all patients, TAILORx showed us if your recurrence score is 0 to 25, there's no chemo benefit. 26 to 100, significant chemotherapy benefit, with the understanding that young women need to be viewed a little bit differently if their recurrence score is 16 to 25. So we looked at women over 50. 15% of them are sitting in that range where they should strongly consider chemotherapy, and women 50 and younger, we have 50% of patients who absolutely should not be considered for chemotherapy, even with big cancers or big aggressive cancers. This recurrence score information gives you much better biologic information about your breast cancer than any other feature. And then you can see the increasing percentage of patients who really, I think these two groups much more strongly need a discussion about chemotherapy. So the last thing we're going to look at is clinical risk. When we add the grade of the cancer and how big it is, let's say that's high clinical risk, high grade, big cancers. We know that from the TAILORx trial that for these patients who have this low recurrence score range where we don't offer chemotherapy, 25% of them are big cancers that are really ugly under the microscope and high grade. And if we never did this test, they would have been offered chemotherapy. And for women with this range where we absolutely think they need chemotherapy, we're finding 43% of them have low clinical risk. They're small cancers, they don't look aggressive, but in fact, their genomic test tells them they absolutely should be considered for chemotherapy. So I'm going to end my scientific presentation. I'm going to hand this over to Bernadette, who also is an employee of Genomic Health. She'll introduce herself, and she can walk us through the rest of this information.
Great, thanks, Christy. And so I'm Bernadette Wong, and I'm from the patient advocacy team of Genomics Health. And as Christy said, TAILORx is really a one-of-its-kind study, not only due to the number of people that the trial enrolled, but also how long the study kept up with people to look at the outcomes and how they did. Now, the actual trial itself took longer than 9 to 10 years. The idea of this trial really developed very early on in the stages when Oncotype was first available, which was about 15 years ago. And I believe in the breast cancer space in the clinical community, the idea of genomics is now a relatively familiar thing. But for the patient community, that may still not always be the case. And we actually worked with SPHERE, which is part of the National Cancer Institute at NIH, to look at the usage rates of genomic testing. And some of the findings really surprised us. Now I'm also trying to learn how to change the screen. Sorry, we're going through. Sorry about that. And so one of the findings that we saw was that younger and older patients were far less likely to get the test than the more traditional or typical ages of breast cancer patients. And especially, as Christy had mentioned, looking at the younger patients and oncotype scores, that's a really important population. When we looked at the data, we found that testing rates in younger patients 40 and under were 1.5-fold less than patients 40 to 70. And genomic testing rates in patients 70 and older were 3-fold less compared to younger patients. And we believe this is partially driven by assumptions people may make about age and breast cancer. For younger patients, the assumption still exists that all young breast cancer patients have aggressive cancer and they all must be treated aggressively. Now we know that that's not true. Not all young patients have aggressive cancer. Not all young patients need chemotherapy. On the flip side, for older patients, there may be assumptions that they have less aggressive cancer, or they may be too, quote unquote, weak to withstand chemotherapy. But there are older patients who are healthy, and in some cases healthier than some young patients, and they may need chemotherapy and would benefit from chemo. And so as a result of some of these assumptions, we may be seeing that younger patients are getting overtreated and older patients are undertreated. And that's why we created this campaign called No Matter My Age, to highlight some of these issues and to encourage patients, no matter their age, to learn as much as possible about their breast cancer options before making a treatment decision, including asking their doctor about a genomic test if appropriate. And the site includes patient videos, stories, some facts and statistics, and I just encourage everyone to visit the site at nomattermyage.org to learn more and share the message. Since you guys will have the slide deck after this webinar, I've just included some additional patient resources that may be helpful. There are sort of 101 breast cancer information sites. This is a site and app that patients can use and take with them. They actually can get a personalized treatment report based on their pathology. My Breast Cancer Treatment is a site for those that are interested in genomics and learning more about what genomics is, what the test does, and learn, if it's appropriate for them. And just quickly before I wrap up, I wanted to also highlight that Genomic Health does have a patient assistance program for any patient. Oncotype is covered by Medicare and all major insurance companies, but for those who don't have insurance or are underinsured, the patient assistance program is available to help, and people can either call or email the team directly to learn more. And so, Christy, I'll hand it back to you.
Okay, that's great. Okay, so thank you everybody for listening in, and now we're open for anybody who might have questions. And I believe you're supposed to type the questions in if you'd like to. So I see a question here. We know now there are different kinds of T cells in our body. Considering more use, I'm having trouble seeing all of these. So let me see if I can see this better. I'm just a doctor. I'm not a great technician. Oh, I think there's a question about CAR T cells and that sort of thing. So breast cancers, these different kinds of breast cancers, some have more immunity than others, which means that the immune system of the body is trying to recognize the cancer cell and is trying to wall it off, or trying to kill it off in some way. And these new immune therapies are trying to really expand the ability to help the body's immune system recognize cancer cells and burn them out. Genomics at this point has not been able to figure out who will and will not benefit from immune therapy, but there are some protein tests that are being done now on certain cancers to see, they're called PD-1 or PD-L1, that to help understand the immune system cells around the cancers and whether they would be receptive from specific therapies to ramp up the immune system to try to wall off the cancer. So that technology is continuing. I can tell you for estrogen receptor positive, HER2 negative breast cancers, it's just been, these tend not to be that much, have that much immunogenicity, and just tend not to be able to have the immune system be effective for them. Okay, we finally figured, Bernadette, my IT guru here, has finally figured out how to show these tests, these questions. So I hope that question answered the issue about T cells. It's different kinds of testing, but these are tests that are done on the cancer, actually the immune cells that sit around the cancer cells for specific types of breast cancer, although not necessarily cancer cells that are estrogen receptor positive and HER2 negative. And right now, this technology is being used predominantly in metastatic breast cancer. All right, so there was a question about how do we access the slides. And the website, I believe they're going to make the slides available through the Triage website. There's a question about the role of genetic counselors in regards to genetic and genomics. So genetic counselors work very closely with the medical team, but this really is on heredity. So when the doctor sees a patient has a cancer, we are, as physicians, really should understand the patient's family history, the specific cancer they have, and that can give us clues as to whether that patient's at risk that she or he could have been born with a hereditary gene, and then the referral will go to the genetic counselor, who will work closely with the oncologist or breast surgeon, because we make decisions about not only the type of surgery, but types of therapies as well. But I would say hereditary genes are the purview of the genetic counselors. Genomics really is coming through the physician, either the breast surgeon in this case or the medical oncologist. There's a question about, as a social worker, how can I advocate when a patient asks for resources to give them options to contact Genomic Health or another multi-gene assay company? Can you cover Medi-Cal patients or underinsured patients? And Bernadette's going to manage that question.
And I'm hoping, can people hear me? Okay. All right. I just wanted to make sure. I wasn't sure if my mic was working. For the first part of the question, in terms of advocating for a patient asked for resources, I would say some of the websites that I included in the end of the slides would be very helpful for direct information. There's also oncotypeiq.com. There's a patient section where they can also learn more about the test. And in my breast cancer treatment, there's actually a doctor discussion guide that patients can take in to their doctor's appointment and really ask some of those questions. And in terms of, let's see, the second was Medi-Cal and underinsured patients. So yes, it is currently covered within Medi-Cal. And for the underinsured patients, I again would reference the patient assistance program, and for any patient or even the social worker to contact Genomic Health to help them see what type of assistance is available.
Thank you so much, Dr. Russell, for that great presentation. That is all the time we have for questions today. If we weren't able to get to your question, please feel free to reach out to us by email.
And this is Christy. I just want to thank you very much for allowing me to do this presentation today. It's very much appreciated.
Of course. Before we go, I wanted to remind you all of the requirements to receive contact hours. You must have registered online for today's session. People who are listening in on someone else's computer are not eligible for credit. You also must have attended the entire webinar. No partial credit will be awarded. Anyone watching a recording of this webinar will also not be eligible for credit. Within 1 week of this webinar, complete an evaluation and post-test. You must receive a passing grade on the post-test to be eligible for contact hours. You will receive an email following this webinar, which will contain a link to the evaluation and post-test. Please note that on the evaluation, it asks for your name and email address. You must include these so that we can certify that you completed the evaluation. That email is the address we will use to mail the certificates. We will be sending out certificates within 4 weeks. For other types of healthcare professionals, we are more than happy to provide a general certificate of attendance. Just make sure to indicate that request on your evaluation. If you have any questions or experience any problems, email us at info@triagecancer.org. Thank you again, Dr. Russell, for the wonderful content, and Bernadette, and thank you all for joining us today. We hope that you have found this presentation useful and will continue to stay connected with Triage Cancer.